Welcome to Decoding Healthcare Research. I'm your host, Efrain Riveros, Dr. E.F. Rain. Today we will talk about global health, specifically the status of surgical, obstetrical, and aesthetic care in the continent of Africa, and how the continent is progressing in terms of production of research. And for this important topic, we have a special guest, Dr. Emmanuel Ameh. He's a professor and chief consultant and pediatric surgeon at the National Hospital in Abuja, Nigeria. Welcome, Dr. Ameh.
Thank you very much, and thank you for having me today.
Thank you. So first of all, we noticed that more publications are coming out from the African continent. And one of the aspects that called my attention is that this research sometimes is done in collaboration with the countries in Europe and the United States. And that has been happening for a long time. But recently, I have seen more publications generated in the continent of Africa. So can you tell us a little bit about the status of research in your continent?
Thank you. That's a great question. So I think that many years ago, obviously what was happening was that, as you know, the research capacity in Africa is still a bit limited in terms of the infrastructure and the support to carry out good research. Remains rather limited in Africa. And that is why you saw that many decades ago, and even up to now, many of the research outputs coming out of Africa is usually in collaboration with colleagues in high-income countries, largely because many times those colleagues in high-income countries coming with their funding and with their research experience and with their research infrastructure. And that helps to support African researchers to get involved in research. So that has been the main limitation. But over the last maybe 10 to 15 years, what has happened is that there has been so much effort over the years to kind of scale up the research capacity in Africa in terms of the training and funding is still not really available. Most of the researches we do in Africa are done out of pocket, funded completely out of pocket. So most of what you are seeing coming out now is because African researchers are becoming more and more interested in publishing their work. And also that we have some postgraduate training colleges in Africa. For example, the West African College of Surgeons, the College of Surgeons of Eastern, Central, and Southern Africa. They've put in so much effort in trying to train people both in surgical skills, surgical and anesthesia skills, but also in research skills. So that is why you see some increase in the researches coming out of Africa. And I think that another important factor is that many years ago, the only available journals that you could publish your papers in are really journals that are based in high-income countries. There were journals that were indexed in PubMed, in Scopus, and everybody who want to publish their papers in journals that have some impact and visibility. But now we do have quite a large number of journals that are now based in Africa that are more likely to accept manuscripts coming out of Africa. As you know, there is a lot of, I think, politics in quote, surrounding publication of research work. My paper from Africa is less likely to be accepted in a high-income country journal compared to a paper produced by a colleague in a high-income country on the same topic, but because he's based in a high-income country, his paper is more likely to be accepted in those journals. And the reality also is that most journals have their target audience. Many of the journals in high-income countries are targeted to their population. So what the research that I produce may really not be of interest to their audience. And so those journals are less likely to accept them. But again, in the last 10 years or so, many of the journals based in high-income countries have now come to realize that they need to be a little bit more global, and they are now beginning to accept more manuscripts from outside high-income countries. That means from Africa, from Asia, from South America, and some of them have actually created a global health and global surgery section in their journals that are receptive to the kind of researches we produce from Africa. So I think that that's the reasons why you are seeing more papers from Africa now generated within Africa is for some of those reasons that I've mentioned.
Yeah, and I hear you, because in Latin America, the situation where I come from, the situation is very similar. Even though high quality papers and information is produced in those countries, the fact that it's not generated within the US or Europe, it limits their possibilities to be published in high impact journals. That's starting to change, as you mentioned. And my two next questions have to do with individual countries and collaboration between countries. I see that the production of research is not happening in every African country. Some countries are standing out more than others, specifically Nigeria, Ghana, South Africa, for example. Is this happening because of resources? Is there a network within Africa? And my second question that is connected to this, are there what you call in your paper South-to-South collaborations, like collaboration between countries with low income?
Right, great question. Yeah, so I think what is happening is for a number of reasons. One is that the research base, and when I say research base, I mean the individuals that are actually carrying out these researches and the support that they have, is more developed in Nigeria, in Ghana, and South Africa compared to some of the other smaller countries. Many of the countries in sub-Saharan Africa actually don't even have enough surgical and anesthesia and obstetric capacity to commit their time into research. While in Nigeria, Ghana, and South Africa, they tend to have more of those individuals, better developed. In addition, as you know, again, in terms of the economic resources, it's a little bit better in Nigeria, Ghana, and South Africa. So I think that's one of the reasons why that is happening. But in terms of South-South collaboration, yes, in the last maybe 5 years or so, there has been a lot of effort in trying to encourage collaboration within West Africa and within Sub-Saharan Africa. That is still ongoing. We are making some progress, but I don't think that we are where we want to be at the moment. But I think a big challenge remains the fact that funding for research is very limited in these countries, and also the fact that the human resource that are available to actually carry out research is still very limited in many of these countries. So what you then have, for instance, if you have a surgeon who is really interested in doing research, he is simply overwhelmed with clinical work. he simply cannot find enough time to commit to research. And in addition to that, he still has to find a way to earn in addition to what he earns from maybe from his service to a government hospital. So, and then he also still has to find time to commit to training residents. So all those aspects makes it difficult really for them to commit time to research. And as you know, in sub-Saharan Africa, if you are doing research as a surgeon, for instance, you are practically doing it on your own. You have no secretarial support. You have no librarian support. You don't have research assistants. So you practically have to do everything yourself, between yourself and your maybe surgical trainees. So I think those aspects makes it a little bit difficult for many of the countries. A lot of effort is being made to address those issues, but I think that we are not where we want to be at the moment.
And I'm actually familiar with that situation of being overwhelmed by clinical work, which is in the end a priority, you know, to give that service, to provide that service to the population, and that happens around the world. And probably that serves as a segue to the next topic that, and I want to mention a high impact paper that you published in Frontiers in Public Health this year, 2023, titled Aligning Global Surgical Research Collaborations with Local Priorities in Low Middle Income Countries in the World Journal of Surgery. I see that from the political standpoint, the African continent is putting together initiatives to advance as a group of countries, and it called my attention within the context of the Africa that we want 2063 agenda. The African countries and the experts came together to put together the Dakar Declaration. Can you illustrate us a little bit more about this?
Right, excellent. So the Dakar Declaration, it started, as you know, in 2015. The World Health Assembly passed a resolution mandating member countries to include surgical obstetrics and anesthesia care as a component of their universal health coverage activities. Because as you know, before then, most of the focus of universal health coverage activities across the world really were focused on communicable diseases and non-surgical, non-communicable diseases. And surgery, anesthesia, and obstetric care were mostly considered as a little bit too expensive and elitist. But after that, after the declaration, the resolution in 2015, the recommendation was for most countries to begin to scale up surgical obstetrics and anesthesia care. And one of the ways to do that was to create their surgical plans, surgical obstetrics and anesthesia plans within countries. A few countries were able to do that, including Nigeria. But one of the things we then realized was that as of 2020, perhaps only about 5 or 6 countries in sub-Saharan Africa have been able to do that. And without a well-thought-out plan, it's difficult to really scale up surgical obstetrics and anesthesia capacity. So what happened with the Dakar was that the Mercy Ships, which I'm sure you probably know about, the organization that takes ships to many low and middle income countries and provides surgical care from the ships, as part of their celebration of their 30 years of service in Africa, they wanted to support surgical obstetrics and anesthesia care. And one of the things then, they put together a group of surgeons, obstetricians, anesthesiologists, and the surgical colleges. The West African College of Surgeons, the College of Surgeons in East and Central Africa. And we were mandated to come up with a plan that will be able to help entire sub-Saharan Africa to commit to investing in scaling up surgical capacity. So one of the things we did was, so I chaired the scientific program and project. So we embarked on a baseline assessment across the 47 WHO Africa countries. And what we wanted to do with the baseline assessment was actually to know what's the status of surgical obstetrics and anesthesia care in the countries. And at the end, we were able to complete that baseline assessment for 32 countries, and which means that we came up with the real data, real-time data about the situation in those countries. And based on that, we were able to bring together the technocrats in the ministries of health of those 32 countries. And they came together and reviewed the results that we generated from the baseline assessment. And they agreed on their own. They set priorities and agreed on what needed to be done. And once that were completed, we then brought together the ministers of health for these countries to look at the priorities and the plan that was created by the technocrats. And they looked at the plan, the priorities, and they were able to agree on a declaration mandating all their countries to commit to investing in the scaling up of surgical obstetrics and anesthesia care in their country. So that was how the Dakar Declaration came about. And at the moment, I think about 5 or 6 presidents and heads of state of African countries have already endorsed the declaration, and the plan is on to get the entire declaration endorsed by the African Union, and then different African countries can begin to invest. So that's the background to the Dakar Declaration.
How many countries were represented there?
32 countries.
32 countries.
Out of the 47.
Yes. Wow, that's pretty significant. That's pretty significant. And what are the metrics? How are you guys going to measure that these plans are going to be effective in the future?
Yes, so as part of the declaration and the action plan, because the declaration also created, I think, about a 12-point action plan about what specific things to do and how to track progress. And the plan is for all the countries to come together every 2 years and present the progress in their countries. And the metrics we plan to use are the same metrics of the Lancet Commission on Global Surgery, which includes the surgical capacity. That means the number of surgeons, obstetricians, and anesthesiologists, 100,000 population. The surgical volume, that means the number of surgeries that are being done. The morbidity and mortality, how much are they tracking mortality in their countries and what is being done. And then financial risk protection. How many, what's the risk of catastrophic healthcare expenditure within their countries over the period concerned. So those are the metrics we hope to use. Those metrics, as you know, are still being refined. For instance, the surgical capacity, the previous focus was on specialist surgeons, obstetricians, and anesthesiologists. But as you know, there are not, you simply can never have enough specialists. So efforts are now on to refine that metric a little bit to include non-specialist providers that have been properly trained to provide basic and essential surgical obstetrics and anesthesia services.
And that's my next question. Specifically in Nigeria, you guys are experiencing shortage of anesthesiologists at this moment?
Yes, certainly. We have huge shortage. Apart from the fact that our current anesthesia maybe by 2 years ago, our anesthesia capacity obviously was below 0.1 anesthesiologists per 100,000 population. And to compound that, in the last 2 years, we have had large numbers of anesthesiologists migrate to the high-income countries and also to the Middle East to earn more money. So that capacity has dropped significantly below. So we have huge shortage of anesthesiologists, such that outside the tertiary hospitals, at the primary and the secondary level hospitals, many of them really don't have trained anesthesiologists. Many of them have to rely on non-physician anesthesiologists to provide anesthesia care.
And are there like formal programs of training for those mid-level providers?
Yes, we do have. Yes, we do have some training. So for the physicians, that's for the what we call medical officers. That's those who have only come out of medical school. There's what we call a diploma in anesthesia training, which they need to do, I think, for about 18 months. But in addition to that, we have nursing anesthesia training schools that train nurses to provide anesthesia care. So we do have schools for that. There's formal training for that. But again, we are not training enough. But in addition to that, as part of the Nigeria's surgical obstetrics and anesthesia plan, one of the things we are at the moment doing, we should kick off in the next few months, is to also create a short-term training to strengthen the knowledge and skills of the existing non-physician anesthesiologists that are providing services at the lower level hospitals, so that they don't lose their skills and then they can practice safe anesthesia than they are able to do presently.
Yeah, in the case of anesthesia, that seems to be a solution. What about from the surgeon standpoint? Because I see more difficult that mid-levels can provide that service.
Yes, so from the surgical standpoint, again, efforts are being made, and I'll mention some of the efforts. Obviously, they are not enough. Several years ago, I think about 10 years ago, now the West African College of Surgeons had always focused on training specialists, fully qualified surgeons, anesthesiologists, obstetricians across different fields. But several years ago, some of the countries in West Africa, some of the smaller countries, reached out to the West African College of Surgeons, and they were like, they simply cannot afford to commit people to that long duration of training, and they wanted a shorter duration of training that will be able to produce middle-level surgical manpower. So one of the things the West African College of Surgeons did was to then split the training program so that after the first 3 years, that was focused on training middle-level manpower. They have enough skills to practice as middle-level surgeons, anesthesiologists, obstetricians, and they can, if they want to exit the program, they can exit the program and provide services as middle-level providers. If they want to continue, they can then continue for several more years and become fully qualified specialists. So that is ongoing at the moment. But in addition to that, as you know, there are medical officers. Medical officers are individuals who have completed medical school, but they have not had any additional training. They are usually the ones providing services at the lower level hospitals. So one of the things we are doing as part of our surgical plan, we have created a short-term training for them in order to scale up their skills. Those short-term trainings are focused on what we used to call the bellwether procedures. That's making sure that they are able to provide to do a safe cesarean section. They are able to do a safe emergency laparotomy, and they are able to treat fractures, long bone fractures from trauma. And for children, we have a set of common children's surgical procedures that we are training them to be able to do. And the feeling is that if we can get them to be able to do a safe cesarean section and a safe laparotomy, it means that they should be able to do many of the basic life-saving surgical procedures at that level. So we are doing that at the moment as part of implementation of our surgical plan.
That's great. And I, I am intrigued about something that you said, the mobility of the physicians who are going to high-income country. Is there also mobility within Africa, like moving from one country to another one because the income may be better?
Yes, there is, but not as much. There are a few African countries that really are paying significantly more than other countries. There are a few smaller African countries, especially in Southern Africa. So there's some migration to those countries as well. Not as much as what is in towards Europe and America and the Middle East. But yes, I agree with you. There's some migration within Africa as well.
And I appreciate the brief overview that you gave us about the situation in Africa, because this is something that is becoming increasingly interesting around the world for different reasons. One, because as you mentioned at the beginning, in high-income countries, the attention is shifting a little bit more to global health, and also because in other countries there are people going through the same challenges in some other areas of the world, as you mentioned, in Asia and definitely in Latin America. And my final question to you would be, do you see opportunities of collaboration between countries and continents sharing the same challenges without even the participation of high-income countries, specifically Asia and Latin America?
Yes. I mean, certainly. I mean, because we do have similar challenges, maybe in slightly different context. And I think that there is so much to learn from each other. And now, for example, in terms of the capacity, surgical anesthesia and obstetrics capacity, some countries have been able to train large numbers. I know Brazil is able to train large numbers compared to many other countries. So there's a lot to learn from them. There are things going on in different countries, in low and middle income countries, that we can learn from each other. And one of the things we realized recently, because a few years ago, maybe about since 2015, 2016, we set up an organization called the Global Initiative for Children's Surgery. And what this global initiative did was to bring together stakeholders that are interested in providing surgical care for children, really focused on low and middle income countries, and brought everybody together. And we also worked in collaboration with colleagues in high income countries. But the entire focus of the organization is about how to scale up surgical care for children in low and middle income countries. And in the last few years that the organization has existed, we have learned a lot from each other across Latin America, Southeast Asia, Africa. So much, we have learned so much, and we have done so much together, such that we are beginning to work together to change the way surgical care is provided for children in this country. So I think that there's a lot we can learn from each other. But I must emphasize that as we learn so much from each other, I think that we still, I think collaborating with colleagues in high-income countries is still very relevant. There's still so much support that we need from them. And I think that, and as you know, even within the high-income countries, there are areas that function or are similar to low and middle income countries that have the same kind of problems that we have. So even for those countries, working together with us is helpful. So I think that we can make a lot more progress if we are all able to work together on mutually beneficial programs with everybody benefiting, without any undue disadvantage or advantage to any component.
I agree. And probably the takeaway of this conversation is that the key here is collaboration. So it's understanding the challenges that are happening in other parts of the world, and see how we can benefit each other from these collaborations. And that I would say brings us to a close here. And first of all, thank you so much for taking the time to sharing this with us. And we will follow up on your research and your publications and the situation in Africa. And I am sure that this initiative that you put together in the Dakar Declaration is going to definitely bring a lot of benefit for the continent and the people in those countries. For our audience, you will find a link to the papers that we discussed today in the description. And don't forget to leave us feedback in the comments section. See you in the next episode of Decoding the Healthcare Research.